Yes,
Moi,
sir.
I am observer, not expert.
Nice, sir.
Observer too is a big post.
Yeah,
United
that's
Nations
definitely.
observer.
Oh, sir.
Lot of power, but nothing he can do.
Mm.
Okay, carry on.
Can you start,
We are
Anjana? Anjana?
we we are live.
Yeah. Should I start?
Yes.
Yeah, please do.
Yeah, good
Come.
evening, everybody. Today,
Uh,
this
uh,
classroom, this course, Dr. Dr. Sir, who is our teacher, who is known to everybody, I requested him to take the chair of expert today in this subject. Next, so I should welcome Sir. The next, Dr. Paramita Chakraborty, a senior ENT specialist who is dealing vertigo cases regularly. She will be delivering this very important subject. And again, I'm thankful to this to Dr. Kipamay Nath and Dr. Surajit Burman as a moderator. So I would like to welcome you everybody to start this subject. And please go first. What is called introduction of the speaker.
Uh, I think Dr. Anjan will speak
Anjan.
something about our Dr. Sir, respected Dr. Sir. Yeah.
Yes, madam. Am I audible, ma'am?
Yes, you are audible.
Okay. So, though Dr. Sir does not need any introduction, he is
Introduction.
most lovable and most respected ENT surgeons in entire Northeast India, and he is known all over India.
India.
So, it's a great honor to introduce Dr. Sir. He's a pioneer of healthcare and education in the Northeast India. So, I'll read out few lines from his long biodata. So,
Oh,
Dr. Sai is the chairman and managing director of Downtown Hospital and founder and chancellor of Assam Downtown University. He completed his MBBS from Guwahati Medical College in 1965, in second in position, and in the university, and went to do his masters in ENT from AIMS in New Delhi in 1970, standing first in his batch. He was awarded the British Commonwealth Fellowship and received advanced training in microsurgery of the year in UK and France. He also holds the FICS title. Dr. Sir served as a teacher in Guwahati Medical College for 14 years before founding Downtown Hospital in 1989, where he continues to serve as an ENT consultant. He has played a key role in organizing and participating in various national and international conferences, and served as a vice president of the East Zone International College of Surgeons India section for 3 consecutive terms. His contributions has been widely recognized, and some notable honors includes International Man of the Year 1992-93, Service Above Self Award by Rotary International, Shiksha Vibhushan in 2015, Son of the Soil Award 2018 by Chief Minister of Assam, Lifetime Achievement Award for Healthcare and Education, and many more. He has also published several scientific papers and authored a book in Assamese titled Horu Horu Kothar Hokura, and currently he also serves as a chairman of CII Assam chapter. We are truly privileged to have him with us today. Please join me welcoming Dr. Sir. Sir, please.
हेलो
yeah.
वो 749 रूम क्लीन हो गया है क्या तो चाबी जाएगी
Thank you very much for the introduction because I
Thank you,
also
sir.
forgot few of the things.
He actually
You have
did not.
reminded me. Thank you so much, Priya.
Thank you. Thank you. Most welcome, sir.
Okay.
So good evening, everyone. Welcome to our Neboy classroom. So today's speaker is Dr. Paramita Chakraborty. She is a senior consultant of ENT and neuro-otologist of Central Railway Hospital, Maligaon. Also, she is associated with Swagat Super Speciality Surgical Institute, Maligaon, Guwahati. She was trained in neurootology under Dr. Anirban Biswas, and she was also DNB teacher at Downtown Hospital from 2004 to 2010. She was also trained in upper GI endoscopy and bronchoscopy in 2008 at Northeast Cancer Institute. She presented numerous podium presentation in neurootology in national forum. She is a guest faculty in many national and international, also in the journal conferences, and completed advanced course in assessment and management of vertigo and balance disorder under Dr. Srinivas Dorasala from Yenapaya University, Mangalore, India, and International Rehabilitation Certificate from American Institute of Balance, Florida, USA. So this is a short biodata of Paramita Chakraborty. We have two learned moderator among us. One is Dr. Kripa Moynath. He did his MBBS and MS from Silchar Medical College, Silchar. Presently, he is the Associate Professor of Silchar Medical College since 2020. He has numerous presentation publications in the journal and national level. He presented many papers and delivered lectures in NEBOI and AOI conferences. He completed certificate course in assessment and management of vertigo, and and balance disorder from Yanapa Medical College, Mangalore in 2024. He is a member of various associations like AOI, FHNO, Indian Society of Otology, IMA, and also a member of NEBOI. The other moderator is Dr. Surojit Bormon. He is a consultant neurologist at Center of Balance Disorder and Rehabilitation at Guwahati. Presently, he is the Vice President of Neuroecolobiometric Society of India. He is the faculty and certificate course in assessment and management of vestibular diseases at Yenapaya Deemed University, Mangalore. So I now welcome Dr. Paramita Chakraborty to deliver her lecture. She is going to speak on so-stone approach, a common sense approach of diagnosing a dizzy patient. Over to Paramita.
Thank you so much, ma'am. Good evening, everybody. Good evening once again. Respected Anandatta sir, Professor Khanna, Professor Birajdas sir, Dr. Anjana Sharma, Dr. Anjan, our respected moderators, Dr. Kripamoy and Dr. Surajit, all my senior and junior colleagues, all the PGTs, and ladies and gentlemen. Today I'm so honored because I'm presenting in front of Datta sir, because way back in 2004, it was Datta sir who introduced me to the world of vertigo, you can say. At that time, there were very few vestibular specialists. Then Datta sir told me that, why don't you get trained in this field? And now here I am. So thank you, sir. Thank you very much, sir, for introducing me to this field of neurootology. So today I have chosen so-stoned. It is a very common sense history-taking approach in a vertigo patient. I've chosen this topic because we find that in diagnosing a case presenting with vertigo, history taking is very important, because history clinches the diagnosis in about 80% of patients. So I've chosen this topic. The so-stoned is actually a mnemonic which was given by a very good scientist, Dr. Watts et al. In the year 2016 from the University of Antwerp, Belgium. So I'll start with my topic now. Why is history so important? History is very important, as I said, because 70% of the dizzy patients can be diagnosed with a careful history. So history is important to understand the disorder, to know the differential diagnosis, qualitative information, and to know the type and extent of the disability. Now, so-stoned, it is a mnemonic coined by Floris L. Watts et al. In 2016. It was coined to aid in the diagnosis of vertigo. So, excuse me, I'm just not. Anjana Bhai, can you just mute these pictures? To be able to see.
Pardon? Introduction pictures, it's coming.
Yeah, no, it's coming. Yeah. Though, patients with vertigo present a relatively large group in our society. Approximately 30% of vertigo present with a moderate to 30% of people present with moderate to severe dizziness in some point of their life. 80% seek medical care at some point, though most people report non-specific forms of dizziness. Nearly 25% of these people report true vertigo. Hence, the proposed mnemonic "so stoned." So, so stoned, it stands for S for symptoms. O is often, how often we get the vertigo. Again, S is since when. T is the trigger. What are the triggers for the vertigo? O, the autological causes of vertigo. N is the neurological causes. E is how the disease has evolved. And D stands for duration. So this so stoned has revolutionized the diagnosis of vertigo, and with this so stoned approach, it can guide the clinician in his or her decision scheme for identification of the appropriate vestibular diagnosis. Now we come to the symptoms. See, when we take history in a vertigo patient, we have to give a lot of time to the patient, because history taking in a vertigo patient cannot be done in a 5-minute OPD setting. So at least we have to sit with the patient for 45 to 50 minutes for a careful history taking and examination to come to a probable diagnosis. The patient may give these bizarre symptoms. Like most of the patients, they come by the mood khuri. So very vague symptoms. If you ask them whether the world is rotating or their head is spinning, then they'll say, no, I'm just feeling bad. I'm just feeling lightheaded. I'm feeling dizzy. I'm feeling instability. So lots of problems. So lots of bizarre symptoms. So you have to ask leading questions in such cases, because characteristic of the symptoms help to locate the problem. So it is very important. So first, let us discuss spinning. So spinning, it is the illusionary sensation of rotation, and it primarily refers to the semicircular related problem or its pathways, such as vestibular neuritis, benign paroxysmal positional vertigo, superior semicircular canal dehiscence. So, and it also may occur, the spinning sensation may occur in ominous symptoms like stroke even, because we see that the peripheral vestibular structures, they receive their innervation from the peripheral processes of the bipolar neurons of the vestibular ganglion, which is located inside the internal auditory meatus. As the vestibular portion of the 8th cranial nerve, these central processes, they entered the brainstem at the pontomedullary junction and project to the vestibular nuclei or the flocculonodular lobes of the cerebellum via the inferior cerebral peduncle. So from there, again, fibers from the vestibular nuclei, it goes to the spinal cord, it goes to the extraocular muscles, it goes to the cerebellum, it goes to the thalamus. So wherever there is an infarction in this region, this will automatically present with spinning and other vertiginous symptoms, vegetative symptoms like nausea, vomiting, mimicking a peripheral disorder. So whenever we come across such symptoms, so we have to think about the differential diagnosis of stroke also. So immediately when a person complains of the symptoms of spinning, we have to keep the differential diagnosis in mind, and then we have to think how we will differentiate between these problems. So now, though we are discussing only the history, I'll just briefly emphasize on how to differentiate between these problems. Like in an acute vestibular syndrome, when the patient comes to us in the emergency room, we have to rule the peripheral disorders from the ominous disorders. So what we do, we generally do the HINTS test. HINTS test is the head impulse test, nystagmus, nystagmus test, but head impulse test is found to be positive in peripheral disorders. But in some cases of ICA stroke, also the head impulse test may be positive. So then we look for the other ominous signs like skew deviation, vertical nystagmus, direction changing nystagmus. So that way we differentiate the different causes of spinning. So the second cause is imbalance, postural instability or oscillopsia. So if a person comes with instability, he himself will give the diagnosis. The person will say, if I'm sitting, I'm fine. If I'm lying down, I'm fine. It's fine. It's only when I get up and start walking, I get this imbalance. I get this postural instability. So postural instability, immediately the thing which will come to our mind is bilateral vestibulopathy. In bilateral vestibulopathy, there is postural instability. Other common causes of postural instability are cerebellar ataxias, peripheral neuropathies. So when this few differential diagnoses come in our mind, again we will think what tests we will do to differentiate these problems. So what tests we will do? If there is bilateral vestibulopathy, we will do a head impulse test, which will be positive bilaterally, or sometimes we will do a foam test, like we will ask the patient to stand on the, close his eyes and stand on the foam surface. So if in case of bilateral vestibulopathy, the patient will fall. Then to rule out cerebellar ataxia, we will do the cerebellar test. Everybody knows about the cerebellar test. We'll not go into details. To rule out peripheral neuropathy, we will take at 128 hertz tuning fork, strike the malleolus, check for the vibration vibration. That is typically what we do in the OPD. The next symptom, lightheadedness, dizziness, or feeling faint. These symptoms are typically seen in functional disorders, panic attacks, postural phobic vertigo, or agoraphobia. So nowadays, the postural phobic vertigo, it is usually termed as persistent postural perceptual dizziness it is proposed by the Berenice Society and also included in the World Health Organization. So basically this lightheadedness, dizziness, or feeling faint, we usually see in the psychogenic vertigos. Psychogenic vertigos, as I said, like panic attacks, agoraphobia, and recently triple PD. It may also be seen sometimes in cases of migrainous vertigo, that is vestibular migraine, or sometimes in cases of stroke also. The next symptoms we commonly encounter are falls. The patient will give history of falls. So once the patient gives history of falls, we have to establish one thing, what type of fall he had. Sometimes the patient will say, I do not realize, suddenly I found that I had a fall as if somebody was pushing me hard. So these are typically seen in vestibular falls. Like a person, it may happen in Meniere's disease when a person has Tumarkin's autolytic crisis, or it is seen in vestibular migraine. Vestibular migraine, if a person has sleep deprivation, after waking up, suddenly he has these vestibular falls. And sometimes it is also seen in vestibular paroxysmias. Vestibular paroxysmias also, a person may have short spells of dizziness associated with falls. So vestibular falls are usually with force, but a fall may be there in stroke also without loss of consciousness. So how will we differentiate? In case of stroke, the person is usually called a found faller. Like the patient falls down, he's unable to get up. Usually in vestibular cases, the person is able to stand up straight. Even in an emergency room, when a patient comes with acute vestibular syndrome, usually the patient with peripheral vestibulopathy, he will be able to stand. But a patient of stroke is not able to stand, or in fact, he falls down with a limb. So other symptoms may be loss of consciousness. Then loss of consciousness also is very important, because the person may give a very vague history. He'll say that I was unconscious for half an hour. So if you ask, if you were unconscious, were you aware of the surroundings? Then the person may say, yes, I was unconscious, but I knew what other people were talking, but I was not able to speak. So in that case, you immediately have to think that it is a somatization disorder, because it's functional. or sometimes we have to elicit from the family members. Sometimes it may not be loss of unconsciousness, it may be unresponsiveness. The family members will say that the patient, he complains of dizziness, then suddenly he becomes still with wide open eyes for about a few minutes. So these are typical of partial seizures. And sometimes a patient of stroke or TIA may say that I had blurring of vision and was unconscious for say 1 to 2 minutes. So loss of unconsciousness is very important. If the patient is unconscious, then he is not our patient. Then we will refer him to our neurologist friend, or we will do some tests to rule out any neurological disorders, like we'll send him for imaging, we'll send him for EEG, etc. So these symptoms are very important. How often? So that is how often a person gets this dizziness. Single attack of vertigo is a hallmark of acute peripheral vestibulopathy, vestibular neuritis or labyrinthitis, as well as stroke. A person who complains of three or four attacks can never have vestibular neuritis. It is like, Bell's palsy. A person can have it once. Very rarely a patient will get it twice. So vestibular neuritis or labyrinthitis, it is only a single attack. After a person has a vestibular neuritis, later on he may have secondary BPPV then or persist triple PD. So he may get number of attacks. But if it is a case of vestibular neuritis, it is only a single attack. And it may be a single attack in a TIA or stroke also. Attacks that occur almost daily are typical for BPPV. The BPPV person may have several attacks in a day. Even in case of vestibular migraine, a person may have several attacks. Perilymphatic fistulas also may have several attacks due to straining, even superior semicircular canal dehiscence, and also vestibular paroxysmias. Sometimes vestibular paroxysmias and BPPV are confused. Like today only I was telling Anjana Baidu, some people have several attacks in a day, but whenever you do the positioning test, you do not get any signs. If you get signs, okay, yes, these are true BPPV, you get them corrected. But some patients of vestibular paroxysmia, also they have positional, like they said that with change of position, I get vertigo, but you do not get the signs of BPPV. So you have to differentiate by doing the positioning maneuver and see. When primarily spontaneous attacks occur several times in a day, the likelihood of vestibular migraine decreases as compared to vestibular paroxysmia. Like vestibular paroxysmia, because of the nerve and vessel compression, it may occur in bursts spontaneously. Patient may have 50 to 20 attacks in a day. So vestibular migraine also may have several attacks in a day, but this is very uncommon. This goes more in favor of vestibular paroxysmia. Now, Meniere's disease. How often? Meniere's disease, vertigo attacks occur more than once. But in case of Meniere's disease, the person will have symptom-free intervals for weeks to months. And in Meniere's disease, the person will have associated problems like oral fullness, hearing loss, and the person may become completely symptom-free. Even the hearing symptoms may also disappear during the disease-free days. So, that way we differentiate between Meniere's disease, vestibular migraine, vestibular paroxysmias, BPVVs. Chronic vertigo can also be episodic. In some cases of chronic vertigo, we find that the person complains that he has episodic vertigo, like in triple PDs. Triple PDs are episodic. Also, sometimes triple PDs may be continuous. A person may say that whole day I'm suffering from vertigo. So, chronic vertigo can be episodic, and chronic vertigo can also be continuous. Where the symptom severity fluctuates in such a way that some complaints are always present, as typical, as I said, for PPPD. Bilateral or insufficiently compensated unilateral vestibulopathy also have a more continuous character. So now we come to the other S of the source tone, that is sins. how long the symptoms already exist, whether they have existed for one day, whether they had existed for several days, whether for weeks, whether for months, whether for decades. So since when? Since when did the symptoms occur? Additionally, this since aims to identify events that occurred in the past and after which the symptoms all started. Like, for example, in case of vestibular neuritis and labyrinthitis, it almost almost always occurs, and there is always a preceding infection before the vestibular neuritis or labyrinthitis. Then in cases of BPVV, sometimes we will find a preceding head injury. This head injury may also lead to superior semicircular canal dehiscence, perilymphatic fistula, and as I said, BPVV. So insufficient compensation after an earlier period of vertigo can also lead to chronic subjective dizziness, which is a part of triple PD. And also, ototoxic medication or autoimmune disorders can lead to benign vestibulopathy. Now coming to the triggers. Triggers are the provoking factors which cause these vertiginous symptoms to occur. So in case of BPVV, vestibular paroxysmia, triple PD, altered head sensation in relation to gravity may cause the triggering symptoms. So like I mentioned earlier, BPVV, you can definitely do the positioning maneuver, you will get the signs, and so you can differentiate it from vestibular paroxysmia. And PPPD, usually in such cases who have altered head sensation in relation to gravity, they will definitely give a history of previous vestibular insult. Like they may have had a previous history of vestibular neuritis or labyrinthitis. And so whenever, which lasted for several days, and which usually occurred due to change in, during the acute stage, they had severe vertigo and change of position and postural instability. So even now they have that vestibular memory. So whenever they, there is altered head sensation, they have a vertiginous sensation in case of triple PD. Then dizziness due to positional change may also occur in orthostatic hypotension. Like in orthostatic hypotension, the vertigo usually occurs during the erecting phase. Like when the person just gets up, immediately he will have a severe dizziness spell. But to differentiate it from BPPV, again, if we do the positional test or a patient of orthostatic hypotension, whenever he lies in the supine position, he'll say that he's feeling well. So that way we can differentiate, because orthostatic hypotension is also a very important cause of vertigo, which can be diagnosed only by checking the pulse and blood pressure properly in the lying down position, in the sitting, as well as in the standing position. Then another trigger factor is stress. Stress may lead to psychogenic vertigo, functional disorders, Meniere's disease, vestibular migraine, and also triple PD. So we have to, with all the source-tone approaches, putting them in a table, we have to again make differential diagnosis. Then another trigger is sleep deprivation, which may again, and hunger, which may again stimulate vestibular migraine. Another trigger is headache, which we get in vestibular migraine. Then open spaces, a person having triple PD, agoraphobia, may have fear of open spaces. Like if they go to shopping malls, cinema halls, they get a vertiginous sensations. Then loud noise, it's typically seen in superior semicircular canal, loud noise to superior semicircular canal dehiscence. Then changes in ear pressure due to straining, which is seen again in perilymphatic fistula and superior semicircular canal dehiscence. Then darkness. Darkness is commonly seen in bilateral vestibulopathy, because when a patient of bilateral vestibulopathy goes to a dark room, the visual inputs are lost, because the patient of vestibulopathy usually relies on the visual inputs to keep his balance. But whenever the visual inputs are lost, he immediately falls down. Now coming to otology. Otology is the otological symptoms, sudden hearing loss accompanied by single attack of vertigo, may suggest labyrinthine deficiency. In vestibular neuritis, we see that only the vestibular nerve is involved. There are no otological symptoms, or sometimes there may be very minimal symptoms due to pressure on the vestibular nerve, very minimal symptoms. But in sudden profound hearing loss associated with vertigo may suggest labyrinthine deficiency. Then in cases of Meniere's disease, as I mentioned, a combination of tinnitus, hearing loss and pressure in the ears or oral fullness is suggestive of Meniere's disease. And in case of a third mobile window lesion, we often find that the patient has autophonia or hyperacusis of bodily sounds. That is, they keep on hearing even the eyeball movements or pulsatile tinnitus. So this is typical of the third mobile window lesions. And if in case a patient complains of such lesions, these should be immediately excluded by means of temporal bone imaging and or VAMPs. Then the next is neurology of the source tone. N is neurology. This dimension serves to rule out lesions of the central nervous system, such as posterior fossa ischemia, which can be screened by the Hinds tool. But again, I said that the head impulse test may be sometimes positive in the ICA stroke also. So then you have to have other differentiating features. And also, like if you find such ominous signs like skew deviation or central or vertical nystagmus or direction changing nystagmus, then you have to immediately send the patient for imaging to rule out the ominous neurological disorders. Additionally, in the neurology, even vestibular migraine falls with its typical characteristics such as headache, photophobia, phonophobia, past history of migraine, paresthesia, diplopia, etc. Then the absence of the specific neurological symptoms increases the likelihood of peripheral etiologies that present with episodic vertigo attacks such as Meniere's disease, BPVV, third mobile windows lesions, etc. Now, evolution of the source tone, this E is the evolution. Vestibular neuritis is typically very disturbing in the early stage of the disease. Early stage patient will have many vegetative symptoms like nausea, vomiting, instability, but with gradual improvement because of the vestibular compensation, the patient improves over days. Then Meniere's disease is also characterized by sudden vertiginous attacks with vertiginous attacks with vegetative symptoms, oral fullness, hearing loss. But then again, after a certain period of time, the patient will have no vertigo, no oral symptoms in between. It may be for months, days or months altogether. All other forms of vertigo, they have a typically stable course or are characterized by progressive or fluctuating severity of symptoms. But one disorder we find that it gradually worsens over time, that is PPPD, because it is also a psychological disorder. So what happens, a person, if he is not treated early, it gradually worsens over time. Now, duration. Duration is very important. A short duration, seconds to minutes, it usually occurs in BPVV, vestibular paroxysmia, perilymphatic fistula, superior semicircular canal deficiency, vascular insufficiencies. Intermittents, 20 minutes to 2 hours. It occurs in Meniere's disease, metabolic disorders, migraine. But here I would like to mention that migraine may also be due for a fleeting period of time. Like in case of migraine, the attack may be for a few seconds to few minutes to about 72 hours. So migraine has numerous presentations. So it may be short duration also, it may be of intermittent duration also. Long durations lasting over 24 hours, again migraine, temporal bone trauma, stroke, multiple sclerosis, autoimmune ear diseases, and persistent triple PD, bilateral peripheral vestibulopathy, functional dizziness, neurodegenerative disorders. it should be noted that vestibular migraine, as I said, it can last for a period of 5 minutes to 72 hours. Now, this finishes the source-toned the method of diagnosis. But in the source-toned method, we find that there are some points were lacking, which I will go into mention very briefly. Like drug history, we find that 23% of all medications list dizziness as the possible side effect. Most of the causes, medicines being prescribed for vertigo itself cause vertigo, like tricyclic antidepressants. Like we usually prescribe them for vestibular migraine, like amitriptyline, then the calcium channel blockers like flunarizine. If you give them for long duration, again, one of their side effect is giddiness. So for the treatment for vertigo itself again causes vertigo. Then there are diuretics, which again cause dizziness. Then calcium channel blockers, then benzodiazepines. So these all drugs have vertigo as a side effect. And the adverse reactions are more common in the elderly because they cause delay in compensation also. So again, these medicines will, or they depress the compensatory mechanism and further leads to vertigo. So in the history, we have to inquire about the medications which the person is taking for his present conditions, as well as what diseases he's suffering from. We have to take the history about the medications he's taking. Now, another, this metabolic disorder, this was also not mentioned in the source-toned approach. So we have to ask about the different metabolic disorders: uncontrolled diabetes, hypo and hyperthyroidism, renal failure, hepatic failure, which leads to anemia, which again leads to giddiness. Then dehydration. Dehydration will again lead to giddiness. Then so on and so forth. So there are many metabolic disorders which itself cause, like hyperlipidemia, they itself cause vertigo. So we have to ask in details about metabolic disorders. And most important, family history. Family history is very important. This was also not mentioned in the source-toned approach, but family history is very important for certain types of diseases presenting with vertigo, like vestibular migraine, Meniere's disease, seizures, and autosclerosis. So the acronym source-toned is suggested to cover 8 different dimensions while taking systematic history in a vertigo patients. Since the most common vestibular diseases have different fingerprints, when all the dimensions are considered, we can arrive at a suitable diagnosis. And as I mentioned, 2 or 3 points have been left out, which I have just enumerated. And I'll just show you a slide. I don't know whether it will be visible properly here or not. This is how the diagnosis of source-toned approach helps in the diagnosis. Like the PG students can take a screenshot and enlarge and see. It is given so beautifully. It was given by White et al. So if you see this chart, you will feel that it is very easy to diagnose a case of vertigo from the history alone. This it's not, I could not give it properly in this slide because in the big screen it would have been visible well, but in the small screen it's not really well visible. And so anyway, it's given in the main paper. You can always read the paper, which was written by White et al. And this is very beautifully given. So from here, if we go through them, we will find that vertigo diagnosis is very easy. So this is all I have to say about the history taking. Thank you very much. Thanks for a patient listening.
Can you stop sharing your slide?
Yeah.
So that I can spotlight the
yes,
moderator.
yeah. I'll just give me a second.
Dr. Sir, can you unmute yourself?
I'm not being able to do it, you know. I don't know why, what happened, I'm sure. Yeah.
Dr. Sir, can you unmute yourself?
Stop share.
Dr. Sir? Yeah.
Okay.
So over to you, sir, for your expert opinion.
No, I was surprised and highly impressed by Paramita's speech.
Thank you, sir. Thank you
Paramita,
so
I
much.
knew here. She started our vertigo clinic, but she excellent. She has covered a lot of things there. But as for fall, Paramita, simple fall may cause vertigo. There is no concussion, nothing. But after 2-3 days rest, patient become all right. Then I had seen a case of cerebellopontine angle tumor. That was actually only one case I have seen in my lifetime that caused serious vertigo, and Dr. Rahman had operated that tumor. That patient became all right. And then psychogenic vertigo, psychological vertigo is very important. Many patients have got some problem in their personal life, so it manifests as vertigo.
Yes,
And
sir.
then physiotherapy. In treatment of vertigo, I think physiotherapy has got a major role besides your medicine. So physiotherapy, actually you have got a very good team and a lot of patients come for physiotherapy. Even my patients go there. I don't see a lot of patients, but physiotherapy helps quite a lot. So this is what I want to say. I am very grateful to whoever has proposed my name, and I shall be interested to join again. Sagota?
Yes, sir. Paramita delivered a very nice and
Very nice.
it is a very practical speech actually. I think it will help our young ENT surgeons how to diagnose a DG patients. So very practical things he is speaking. And although there are many tests, that laboratory tests can be done to diagnose a DG patient, but these practical things are very important. So now I request our honorable moderator to comment or give light on this topic. Dr. Kripamoy and Dr. Surajit Burman, please.
Wonderful talk by Dr. Paramita. It was interesting to listen your lecture.
Your voice is a bit low. Can you?
It was a wonderful talk by Dr. Paramita, and she has covered everything nicely. So we have some questions there in the chat box. Take up those questions.
A very nice presentation, and I think, as already mentioned, history is the most important investigation as far as a vertigo patient is concerned. So we'll straight away go to the questions if everybody permits.
Yeah, I take up the question by Dr. S.B. Fugan sir. Why and when Hints Plus is done?
Actually, as I mentioned, hints, hints is like sometimes in case of stroke also, the head impulse test may be positive. As I mentioned in ICA stroke and all. So in such cases, a hints plus, that is, we have to do the bedside assessment of the auditory functions.
Auditory function.
Yeah. So, but hints plus, still Barani Society has not approved of it, no, Surajit? Hints plus, Kripamai?
Yeah, I got somewhere that the Hints
Hints
Plus
Plus is a newer concept that
Newer
has come in
concept,
for the
yes,
last
it is
2 years,
coming.
but it is not yet
Approved by the Barani Society.
legitimized by the Barani
Yeah,
Society.
yeah,
Yes. But it's a very good
legitimized.
concept.
But it is a very good thought, and like nowadays, most of the we do not have, like one of our teachers said, we do not have central and peripheral vertigo. We said that vertigo occurs if the semicircular canals are involved. Vertigo is because of the semicircular canal and its pathways. If otoliths are involved, it is because of the otoliths and and autolytic pathways. So that way, this concept Hinds plus has also come. So whenever you are you have some difficulties in diagnosing a stroke from a peripheral cause of vertigo, then we go for the Hinds plus tests.
Okay.
So to check the neurological aspect also.
Okay, one more question by Dr. S.B. Fugan, sir. When a pre-syncope or syncopal, pre-syncope and syncopal history given, what should we suspect? Pre-syncope and syncope.
Yeah, syncope, when a syncopal history is given, we should suspect a heart block initially. We should immediately get an ECG done. It can be due to vertebrovascular ischemia also. You can do a carotid Doppler of the neck vessels.
EEG can be done also.
ECG.
EEG.
See, in syncope, we do not do the EEG. EEG, if we suspect a partial seizure. Yes, sometimes a person may have blackout, unresponsiveness. For seizures, that unresponsiveness or unconsciousness is a must. Then only we go for the EEG. Otherwise, if in case of syncope, it goes more in favor of the, the cardiological. So if we get a ECG done, if there is very low pulse, then we go for a Holter and all these things.
And we have to see the hypoglycemia.
Hypoglycemia, yes. Hypoglycemia, dehydration, all these causes were, as I said, so stone, they did not they did not talk about the metabolic disorders. So we have to take in consideration about diabetes, what type of drugs he's taking, insulin, because hypoglycemia again causes severe vertigo. So all those things are the additional things along with the source stone, which will help us in coming to a diagnosis.
Okay. Now, one more question is there by Dr. S.B. Fugan, sir. Triple PD, is it functional or psychogenic?
See, triple PD is, you can call it both. Triple PD is not functional, it is psychogenic, definitely, because usually triple PD patients, we find that they have had a history of vestibular insult before.
Somewhere.
Yeah, someday, somewhere, whatever, whether it be a head injury, as Dr. Sir was saying, it may have been a person has fallen, head injury, maybe after 2-3 years, he will come with that problem. So it is definitely not functional. The person has a problem. He definitely has a problem. So we have to address that problem. It is because of a previous vestibular insult. Like if a person has vestibular neuritis, following that, he may have triple PD. He will remember, his vestibular system will remember that insult. And now it may be psychogenic, like whenever his head moves, he feels that he's having that vertiginous sensation. Or we have to also, one thing I mentioned, you have to ask whether the person has preceding things, whether he has undertaken any journey, whether he has undertaken a journey by train, boat, aeroplane. These patients also, if they has had journey related vertigo, that can again lead to triple PD later on. Whenever they undertake the journey, they have the memory. The vestibule has the memory of the previous thing. In mal department syndrome and all, these also lead to triple PD later on, because these are all psychogenic aspects.
One more thing, we should label them as a triple PD, not as a psychogenic person.
Yeah, I didn't get. Kripama, can you be louder?
We should label them as a triple PD patient rather than diagnosing them as a psychogenic vertigo.
Because nowadays, nowadays they have leveled this like that. Previously we used to call it postural phobic vertigo or psychogenic vertigo, but now the Barani Society has named it as triple PD.
Yes, it's a triple PD. Okay, now next question is from the SB Fugan, sir. Super bone conduction in superior semicircular canal dehiscence has any significance?
Yes, definitely. Because the if you take a tuning fork and strike it in the malleolus, it will be audible. Usually we do not get, but in semicircular canal dehiscence, they usually get it.
Their bone conductions goes below 0, I think.
Yeah, then we can do a VAMP and all. Yeah. Usually, ideally, we should go for a VAMP. Semicircular canal dehiscence, only one case I have seen very recently. So I had asked the patient to go for a VAMP, but then the patient disappeared. I had even talked to Gautam that this patient has I got this case because I got only one case in my entire vestibular career. Then I was
how do you investigate for this patient?
No, actually, initially, the patient was sent to me for VNG. I had diagnosed it as labyrinthitis. Then, when we got his vertigo was totally non-resolving, and he had. So we had gone for a temporal bone scan, which showed the semicircular canal dehiscence.
Okay.
Then I had planned to go for a VAMP also, and then I was just asking Gautam da that how do I if he has had seen such disease, because he definitely must have done such surgeries. But then by the time I was deciding what to do, the patient disappeared. He was a very poor patient, so he disappeared.
One more
So
question.
did not come for follow-up. Yeah.
Fugan sir, vestibular migraine or BPPV, which one is common in your practice?
Definitely vestibular migraine nowadays. No, Kripama, even Surajit,
Yeah, yeah.
what do you say? Because
Yeah, yeah.
previously,
Many
now
patients are
definitely
coming.
vestibular migraine,
Vestibular
most of the
bypass.
cases. Because see, about 5-6 years, about 10 years back, that concept of vestibular migraine was not there. Now, like with the concept, like Barony Society's new concepts about vestibular migraine, and once we relate to those problems and give them a treatment for vestibular migraine, we find that the problem is also resolving, and there are more and more cases of vestibular migraine we are getting. Before also the cases used to be there, but it was undiagnosed because we could not, it never used to fall in place. Like before we never used to relate a fall with a vestibular migraine, but now due to sleep deprivation and all, if a person comes with a vestibular fall, we can relate it to vestibular migraine.
Exactly.
One more thing I would like to add, in the recent NEBOICON at Shivsagar, Supriya presented a very nice paper where she did some studies on BPPV. Those BPPV which were not responding to these these maneuvers, she then offered them with this vestibular migraine treatment.
Yes.
And the patient improved. And she
that's what when the patients are with the maneuvers, if they are not responding, or sometimes even with the positioning, you will not get any symptoms, but typically the patient may complain that when I turn my head, I get the dizziness spells and all. So such patients, if you treat them with flunarizine or even magnesium also, because
Magnesium,
nowadays almost in every patient we add magnesium, and with good results.
These patients are traditional nowadays called central positional disorders.
Central positional disorders, exactly. Thank you. Yeah, I was just the thing was not coming into my mind.
One more question from Nityoshwar. Kindly mention various rehabilitation methods or physiotherapy as Sir Datta sir mentioned.
I think this becomes a separate topic for.
That's a separate topic because it's a huge topic.
Absolutely, it's a separate topic. We had a seminar here.
Yeah, we need a seminar
one
here.
physiotherapist.
Rajit has to
She's very
speak on
good.
it because he's the best
gives a
person.
very nice picture.
On rotation, next time, maybe in another 1 or 2 months' time, when neurology topic comes, one of us will present on this.
You invite a physiotherapist, I shall arrange that. And as for BPPV, in ENG, we sometimes find, previously they say don't use any antivertiginous drug. Now they say you can use, but Apple's maneuver, Paramita was doing it very well. Are you doing it now?
Of course, sir. That is.
And now one of our doctors, Sonali, she is doing it. And that helps beautifully.
Yeah. The BPPV definitely it goes with the, and nowadays there are so many.
Diagnosed BPPV only treatment is repositioning maneuvers.
Repositioning, absolutely. Diagnosed BPPV, we hardly, you don't need to do a VNG also.
Our job is to locate the canal involved and the site of the otolith.
But only problem is, following head injury, when you get multi-canal, it is so difficult to treat because you treat one, the patient comes with another problem. So it becomes very difficult to treat multi-canal BPPVs.
Multi-canal BPPV, we have to go with an open mind. Because many times what happens is we do not accept that it's a multi-canal.
Yeah. You have to go with an open mind,
One,
and you have to prime the patient also. That it will
Yes.
take some time. You have to prime them.
so we have one more question from Anjana Sharma, madam. Diagnosed case of Meniere's disease, no acute attack of vertigo for several years, new onset spinning vertigo with falls, important clues in the history towards diagnosis.
I didn't get you. Sorry.
Uh, Diagnosed
So,
case of Meniere's
what
disease.
ma'am I think wants to ask is,
Huh.
this is a diagnosed case of Meniere's disease.
Meniere's
It was
disease, yeah.
diagnosed once, treated, and now for many years there has been no attack of vertigo, no attack of fluctuating tinnitus,
Yeah,
no attack
yeah.
of fluctuating. So we can accept that it has got better.
Better,
Now
yeah.
suddenly this patient
Comes with
starts having
vertigo,
spinning vertigo with falls.
with falls.
Huh?
Yeah.
So, what are the clues in the history which can point us towards a definite diagnosis, whether this is a relapse of the Meniere's disease or this is something else?
See,
So,
it
this
may
is
be,
what I think.
we have to consider the autolytic crisis, Tumarkin's autolytic crisis. That is one consideration. And then we have to think about migraine also. Because as I said, migraine, vertigo and, migraine as vertigo and Meniere's disease, they are spectrum of the same, disease. In one end, you have Meniere's, one end, you have vestibular migraine. So a Meniere's disease, subsequently, Meniere's patient may develop vestibular migraine, and he may have vestibular falls. We have to see what type of fall it is, because in vestibular fall it will be with a severe force, and if you think that it may be a stroke or something, so he will fall in a limb. They are called found fallers, as Dr. Srinivas has taught us. They are called found fallers. You will find that the person, he is unable to get up. Usually with vestibular falls, he will be able to get up and stand straight. So you have to keep those things in mind.
Can I add something?
Yes,
Actually,
yes,
I
yes.
have encountered many cases
Yeah.
with diagnosed case of Meniere's disease, and after many years, he comes with acute vertigo, and then and also sometimes falls. So the best thing to diagnose this case, it is a vestibular fall, definitely. So my first diagnosis was like, is it a migraine Meniere's overlap syndrome? So for migraine, it's a history of the progression of hearing is very much important to rule out whether it is a Meniere's attack or it is a migraine attack. So that's why I have put this question here. So the progression of hearing loss is very much important to rule out the individual attack of whether it is a migraine attack or whether it is a Meniere's.
But the
That's
patient
what
will
actually.
say, na, if he has progressive hearing loss,
That
and you were
sometimes we
saying,
have to ask.
you have to elicit, yeah,
Yeah,
leading
because
questions.
patient is already Meniere's several attack,
Yeah.
he
So
will
if
come
he,
with a hearing loss.
yeah,
So unless and until you mention that how is your hearing, it is deteriorating after your acute attacks were over. So if you say it is same, or if you have a record, you can check it whether hearing is deteriorating in last few years or not. If it is same, then you have to think of it's a case of maybe a vestibular migraine.
or the fall
And
maybe
it
because of
then fall maybe due to
because
vestibular fall.
Tumarkin's, yeah,
Vestibular. It is a vestibular fall.
vestibular
So
fall.
fall. So it's not a Tumarkin autolytic crisis. As it is a migraine attack. So it
Yeah,
has to
migraine may
be
have, yeah.
because like in Tumarkin in many years in vestibular migraines there is a disparity between the resting membrane potential in the vestibular nuclei level, and this disparity actually we perceive only when there is a large head movement, and so the brain perceives this kind of like disparity as a rotational vertigo,
Rotation, and
and
the
patient
patient
loses
falls.
balance and
Balance and
patient
falls.
will complain of fall. Thank you.
Thank you, ma'am.
Paramita, we are
Sir.
talking of Meniere's disease because Meniere's disease is not very common, but you are all talking of Meniere's disease. And then ENG always says a central lesion. When you do MRI or something, there is nothing. That is a fallacy. And I still insist that psychological factor is very important.
It is
That
very
you must,
important, sir.
some patients, especially ladies, Paramita, please don't mind. They have some psychological factor for which they say dizziness, not vertigo. They will never say, and giddiness or dizziness, they will say, but it may not be true vertigo. And psychological counseling is very important. And physiotherapy, I shall still insist, because many of our patients, physiotherapists have cured them.
Yes, sir. Vertigo is a multidisciplinary approach. We need a physiotherapist, we need a psychiatrist, we need a psychologist,
Psychological
everybody.
counselor.
And sometimes we give everything. I mean, we also become psychologists, physiotherapists, everything at times.
So we have one more question there from Anjan Jyoti Bhuya. Can there be short spell of LOC in vestibular migraine fall?
Yes, vestibular migraine LOC means there may be blurring of vision, because in basilar migraine, associated with basilar migraine, the person may have blurring of vision, or they may have, as Anjana Baido mentioned, vestibular falls, so but not exactly loss of consciousness.
Because recently I met one patient. She had a attack of 3 or 4 episodes of short spell of fall. With in those 4 episodes, in one episode she had a history of LOC for 2 to 3 minutes, and in the rest of the fall she don't have any. But I could not find any other cause of
EEG. Did you do the EEG and all?
MRI was, everything was done. She was seen by cardiologist, neurologist.
Very actually rare.
But
since
that
it's a
case, I
circulation.
started with plus 1 month back only. I started with vestibular migraine treatment. But till now, she is fine. I am not yet sure whether that patient is vestibular migraine or something else. The fall
So,
is.
if I may add something, if I may add something, see, on the gist of it, any LOC, we have to rule out central cause. But then, vestibular migraine can bring in anything and everything, because it is basically a problem of the neural integrators in our brain. So because it is a problem of the neural integrators, it will mimic anything and everything. So as Anjana has said, since nothing is there, this is now almost a dictum. When you find no cause of your dizziness, treat it as vestibular migraine. So I think you are absolutely right in doing that. But I'll still say regular follow-up and maybe a repeat radiological investigation, whether CT or MRI, maybe in 6 weeks to 8 weeks time is called for in this patient.
Yeah.
But blurring of vision, yes, it is there in vestibular migraine. No? Blurring of vision is always there. Basilar, especially associated with basilar migraine and all, because of they always have this blurring of vision. Aura, with people with aura and all.
But out of 4, only in one episode she has the LOC.
The loss of consciousness.
But other episodes she could.
There is no more questions there in the chat box. Can I ask a question, Paramita?
Yes,
it's already 9.
Yes.
What is POTS? POTS, P-O-T-S.
It is a tachycardia syndrome. It is like when the person like from the sitting or lying down patients stands up. Usually there is an increase in pulse rate for of 30 beats per minute. So the posture induced tachycardia syndrome.
In your practice, have you found any POTS patient?
Not till date. I have in length heard about it. Yeah, postural hypotension I got, but POTS I did not get till date.
Okay, thank you.
Any expert comment from Surojit?
I think overall, to sum up the whole talk today, as already mentioned, I think this is very, very important. History taking in vertigo patient, because history, as I already said, is the most important investigation, and history taking has different dictums. So stone is one of the most popular one. Another one that is being very popularized, at least nowadays, is not exactly history taking, but overall history taking examination is the diagnostic tree approach by Dr. Srinivas, which we have the syndromic approach that he says, where there is just 8 syndromes, 8 questions, and you come to the diagnosis just looking at that. So Yes. So I think instead of a lot of investigations, although we all, Paramita does investigations, I do, Anjana Vaido does an investigation, what we need to stress is we need to have proper history taking. And the only difference in history taking of a non-vertiginous patient and a vertiginous patient is, in a vertiginous patient, it is imperative that we go for leading questions, trigger targeted questions.
Targeted
And I
questions,
think,
yes.
yes, and in this situation I think data sheet like a source stoned data sheet is very important. So I think very well done. That's what I have to say.
Surely, history taking is definitely very important. But are our doctors so patient to take proper history? I don't think they are not that patient. That is one very important thing. And I think this is a very good seminar. Where is Paramita?
Sir, I'm here.
Where are you? I cannot find. Okay, Paramita, thank you so much.
Thank you so
I
much.
don't
Thank you,
know who
sir.
called
Thank
me,
you,
but
everybody.
I am happy to see Paramita. She was with us for a long time, and she has very nicely presented. Thank you
Thank you
very
so much,
much.
sir. Thank you very much.
Kripamoy, anything from your end?
No, madam, it's okay. Everything went well, and it was a fruitful discussion. And just history taking plus clinical examination, bedside examinations, and some laboratory investigations. Those are the things to come up for a proper diagnosis. Thank you, madam.
So we are coming to a conclusion of this today's classroom. Now it's my job to offer vote of thanks. First of all, I'd like to thank and Dr. Sir for your presence. We are honored for with your presence. Thank you for your valuable input. And secondly, I would like to thank Dr. Paramita Chakraborty. You are in this field for so many years, and thank you for your wonderful presentation. And
Thank you, ma'am.
I'd like to thank two moderators. They are doing very great job in this field, Dr. Kripamoy Nath and Dr. Surojit Burman. Thank you for your valuable inputs and moderating this classroom. And I'd like to thank Anjan Jyoti Via and Dr. Biraj Das and Chairman Dr. Sagata Khanna for your presence. And with this, I conclude this classroom here.